Well, welcome and hi, everybody. My name is Diego Torres-Russotto. I am the chair for neurology at Baptist Health, Miami Neuroscience Institute, and I was the vice chair at the Department of Neurological Sciences at the University of Nebraska Medical Center before moving here, where I spent about 14 years researching orthostatic tremor, and now I'm continuing my work in this wonderful you know disease population. I'm very grateful that you have invited me to speak today and talk about updates on orthostatic tremor research. The stuff that I've been working on, and I'm very glad to be here and sharing with you some of my thoughts about the disease. Let me share my screen here. Okay, very good. So, some people ask me, Diego, why? Why did you start thinking about orthostatic tremor? How did you get so passionate about this? And like for many physicians, it all started by being inspired by a patient. I had a patient who he called himself the shoemaker, and he had orthostatic tremor. And he told me, Diego, I have to keep on walking so that I don't fall. And he made the analogy of like riding a bike. Like when you are riding a bike, if you stop pedaling, then you would lose balance, and that's how he felt the disease was affecting him. And I was just immediately inspired by his story and his plea and his suffering, and by the how interesting this disease was, and I started working on it. So what is orthostatic tremor? Orthostatic tremor is a movement disorder characterized by a shaking in the legs and a sensation of impending fall upon standing. And that's the key, is that the patients have mostly no symptoms when they're sitting, but when they're standing, they feel the shaking, they feel a sensation of imbalance. And then that gets better if they hold onto something or if they start walking after they have been walking for a while, or if they sit back down again. And I was fascinated, have always been fascinated by the disease. I felt from the get-go that it needed to be investigated properly, because it affects the quality of life of our patients dramatically. It is difficult to diagnose, and therefore is terribly under-recognized. And therefore is also terribly understudied. There were no answers to the questions that I had and the questions that my patients had. And also there was no real treatments. If you don't understand what you're dealing with, how can you fix it? And it all started for orthostatic tremor with this paper. Is an Italian paper that was written in 1970, and it's the first account of orthostatic tremor. And what it says is, in January of I speak Italian, so for me it was easy to read this first paper. I enjoyed it very much when I ran into it. So it says, in January of 1968, we observed a patient who was unable to maintain the standing posture due to the insurgence of hyperkinesias, meaning tremor, that compromised the equilibrium. And that's how the whole paper starts. It's a fascinating paper. And it showed this particular figure where you can see that the shakings, the tremor is happening in the arms, is also happening in the legs. And as you can see, it is very high frequency. And when the patient touches the wall, then the tremors decrease dramatically or almost disappear. So what are the diagnostic criteria for orthostatic tremor? It has to be a generalized high frequency, and what we mean by that is 13 to 18 hertz, high frequency tremor. And hertz means the number of times that something oscillates per second. So as you can imagine, if in 1 second the leg has to move back and forth, 13, 14, 15 times in 1 single second, this tremor is so fast that oftentimes the naked eye cannot really see all of the isolation that is actually happening, but the patients do feel it inside. It occurs when standing, as I explained, and it requires EMG confirmation of the tremor frequency. And, it's in the classification, they said that it may be palpable, but it's not visible. They also said that the helicopter sign could be detected by auscultating the lower limb muscles. And there are many other findings that we have and other scientists have been able to find that are critical to orthostatic tremor. OT comes either by itself or in association with other conditions. And you can have, for example, not only the tremor in the legs, but you could also have hand tremors that occur during action. Some patients with Parkinsonism can develop orthostatic tremor, and vice versa. Patients with orthostatic tremor could develop Parkinsonism. And it has been associated with this long list of diseases of the brain. We don't know if these associations are actually causal, meaning if they are related to each other, or simply the patients had the bad luck of having two separate neurological diseases at the same time. This is one of the proposed classifications that I really like. It was published a long time ago, about 20 years ago. It will be 20 years next year. But it divides orthostatic tremor in two sections, the primary OT and the OT plus. The OT plus are those patients who have orthostatic tremor, and on top of that, they have another neurological disorder, another movement disorder like Parkinson's disease. But as you can see, the majority of the patients in this particular paper were classified as primary OT, meaning that that's the main thing that the patients have, is the OT. And that is divided into two sections. Some patients who have just pure OT, meaning this very high frequency tremor in the legs, the arms, the trunk, everywhere. And the other is called OT plus action tremor, which is a tremor usually in the hands that shows up when the patients are performing activities. And it can happen even when they are sitting down. So the usefulness of this classification in my mind is that it actually helps me sometimes find the better treatment option for the patients. So as you can see here in the table, the response to treatment for each of the subgroups is very different. For example, for levodopa, which is a treatment of Parkinson's disease, none of the primary OT patients were having benefit, but about 2 of the 4 OT plus patients who tried it got better, right? So in general, I don't do trials of levodopa on patients with OT unless they also have Parkinsonism. And similar other findings, you can see what is the response rate for each of these medications, and it's all over the place. And we will talk more about my thoughts on treatment in the near future. In terms of the prognosis, the main problem is that we have not properly studied orthostatic tremor to understand the prognosis. But what we know from the literature is that 15 to 60% of the patients feel that the severity of symptoms worsen over time after having the disease for 20 years. About more than 10% of patients will be using a walking aid. They see a clear spread of the tremor to other body parts. And 5% of patients after a long term, like 15, 20 years, about 5% may develop the tremor even while sitting. But of course, as I explained, we need an appropriate study to be able to answer these questions. In terms of the diagnosis, how do we diagnose a patient with OT? This is sort of a summary of my ideas and what is in the literature and the requirements from the current classifications given by the Movement Disorder Society. Primary orthostatic tremor is a clinical entity with that subjective feeling of unsteadiness during stance that disappears at rest or by holding onto something. The neurological exam is normal, except that you have the tremor. Sometimes you can have the tremor in the hands. And there are some abnormalities on examination that we will discuss now that we have found on our studies. But this is the current state of how the diagnosis is made. Orthostatic tremor can be seen in several neurological diseases, and that could be called secondary orthostatic tremor or orthostatic tremor plus. All of these names are being revised over time. And in these cases, then management could be more difficult, but it could also give us new avenues for treatment as well. And then diagnosis, the diagnosis can be confirmed only by the use of surface EMG and the presence of the typical tremor pattern seen in orthostatic tremor. These are my thoughts on treatment options. I always tell my patients that the most important thing that they can do is to enhance their physical activity and exercise. If you are doing nothing, well, start moving. If you have been doing a lot of exercise and physical activity, well, try to enhance that. But what I mean by that is increase the amount of time that you're spending doing exercises, and also expand the type of physical activities that you're doing. So if you were doing walking and biking, well, maybe you want to add swimming to the list, So the more physically active you are, I believe, and it's just a belief, I believe that you will do better with this condition, with this disease. And I have noticed that, I have seen more than 100 orthostatic tremor patients in my career, which is a lot. Most people have not seen more than one or two. And I have noted that the patients who are more active tend to do better. In terms of my first choice for primary orthostatic tremor treatment is clonazepam or gabapentin or pregabalin. And then if that doesn't work, I usually go to primidone, perampanel, and valproic acid. Perampanel has been, on everybody's radar lately because it's the newest drug that we have found that could make a difference in OT. The problem is that the majority of patients don't tolerate the medication side effect. And I'm not sure why orthostatic tremor patients are so sensitive to this medication. Perampanel is an anti-epileptic that is given to many patients with epilepsy in the world, and they tend to tolerate it a lot better than the OT patients can. So that's within itself interesting. If the orthostatic tremor is associated with the action tremor of the hands, even when they are sitting, then primidone and clonazepam would be my drugs of choice. If the orthostatic tremor is associated with Parkinsonism, then remember that OT could be responsive to levodopa. It doesn't seem that propranolol or levetiracetam are useful based on current data. However, propranolol decreases anxiety and it decreases social anxiety. And some patients with OT feel better when they are not as anxious. So it could be that some patients take propranolol and that helps them too. But in general, I don't start with these options and use the other options before. When all of that has failed, the other options to consider are the perampanel and the chlordioxepoxide. And then if medications fail and the patients are still disabled, we still have a few options like deep brain stimulation and spinal cord stimulation. A new option is this transspinal direct current stimulation for managing OT. And the way it works is that you get some pads that are placed on the skin behind your back, and that provides stimulation to the spinal cord and the nerves around in the area. And it seemed that a single session with this transspinal direct current stimulation was able to improve the instability in patients with OT, but this requires more testing. But this is something new that came out in 2021, and it doesn't require a surgery, and it could be really, really, yet another option for our patients. When I started to read about OT, these two pictures basically explain how I thought of it. I thought that the state of OT is that there was nothing. There's nothing. There is not enough data. There is not enough information for me to answer all of the questions that I had about OT. At the same time, the picture on the right also describe what I thought of OT. It's like, wow, we have so many things to answer, so many questions, that need to be answered. That it really looks like a mess. So we decided to create a plan of attack to help our patients and to help answer all of these questions. And we started doing a brainstorming session with a bunch of scientists at the University of Nebraska, and we gathered opinions from other scientists from the world. And then we went and chose the top 100 questions in OT that we needed to answer. And then we went through a process of selection to decide, okay, of these questions, which are the ones that have to be answered first. And I'll give you some examples of how that works, but some questions are very, very important, but we cannot answer them until we answer another question that doesn't feel as important. For example, how do we cure OT? Well, that's a great question, but we might not be able to answer it if we don't know, okay, what's causing OT, right? What's the etiology of OT? So, we went through the selection process to get down to the top 30 questions. And then we created a research timeline, and we aligned projects to be able to answer all of these. And then we started calling patients. So patients came to Omaha, Nebraska during 3 separate meetings. Some of the patients came for all 3, and some patients came for only 1 or 2. And we collected the largest prospective data in orthostatic tremor. More than 100 investigators and study personnel was involved during these, data gathering meetings in 2011, 14, and 17. And patients and control came from the USA, from Canada, from Europe, and even from Australia. And it was there in in Omaha when we decided that September was going to be the OT month. And the reason was because the first meeting was in September. So that made sense. And since then, we have kept our promise to collecting data, investigating. We have presented this information in more than 20 national and international scientific meetings over the years. So out of the many questions, we had, what is OT? Is it a disease of balance or a disease of tremors? How can we measure the severity of OT? And what is the spectrum of the symptoms in OT? These are, of course, very important questions. One of the reasons why measuring the severity of OT is critical is because if we cannot measure the severity, how can we measure the treatment responses? So if we don't have a validated scale, how to measure the disease severity, how can we tell if the treatments that we're trying work, or if it's just the patient's subjective feeling saying, I feel better, and it could be a placebo benefit, right? So that was critical, and this is why I'm so excited that we were able to publish this paper, which was the development and validation of the orthostatic tremor severity and disability scale, which is the short is OT10. And it's 10 because it's just 10 items, and it has been properly studied. The majority of the patients for this study came from our Omaha, Nebraska site, but we were able to produce amazing data to prove the validation of this particular scale, the validity of this particular scale. And we now have started to even translate the scale into other languages. So this is a paper that Dr. Van Roetzeler was leading on the Dutch translation, adaptation, and validation of the OT10 scale for orthostatic tremor. And for me, it's always wonderful to be able to see how many scientists in the world are interested in this disease and are making a difference for all of our patients. So there is always hope of, making a difference, and we will continue to work hard at getting that. Part of our study was to understand the full spectrum of symptoms and signs. What somebody with OT, what are the symptoms? Is it just what they feel, or can we find something else on examination? Can we find something else if we look for it, right? So, having a very large perspective longitudinal study for OT has allowed us to collect a ton of data. Each of our patients has more than 100 patients of data. So that helps us figure things out. One of the findings that we were really interested was from the 2014 cohort that revealed that 11 patients fulfilled criteria for agoraphobia, and 2 patients had panic disorder. One had social phobia, and one had generalized anxiety disorder, meaning that 38% of patients with OT screen positive for one of the multiple anxiety disorders. And about 7% of patients screen positive for current depression. And we thought that that was very useful, very important data. It doesn't mean that anxiety is causing the tremor. What it means is that patients with OT are also suffering from anxiety and some anxiety disorders. We also found in a very good study that looked at this from multiple angles, we also found that ataxia prevalence in orthostatic tremor was very high. In fact, in our study, we were able to see that it was present in most patients. And what's ataxia? Ataxia is just a funny word that we physicians use to call clumsiness. Is an inability to perform movements in a in an organized fashion. So when the movements are clumsy, we call that ataxia. And there are many types of ataxias. You can have clumsiness on moving your eyes, or clumsiness on using your hands, clumsiness on using your legs, and on walking. And we found that patients with OT had a little bit of that, at least a little bit of that, in comparison with the control patients. But there are yet many unanswered questions. Do we know what is OT? Do we know how to best diagnose it? And what are the clinical characteristics? Why do OT patients fall less than other balanced patients? When I talk to my patients with OT, they say, well, we're very careful. And that is true. They are very careful. Why other patients with balance disorders are not as careful about preventing falling, right? So that I think is an important question to answer, because it not only could help OT patients, it also can help patients who are falling from other conditions. An important question remains is what causes OT, and where is the problem in the brain, and are there any issues around that area, and how frequent is OT in the population? What's the prevalence of OT? We don't know this because many patients suffer from the disease for many years before they get diagnosed. Who knows how many patients actually have the disease and have never been diagnosed? Another cool question is why OT tends to affect women more than men. And all of these are, as I said, we listed 100+ questions, right? And all of these are great questions, but we had real and practical problems to fix first. I mean, how can we even start studying a disease that is so rare on patients hard to find, hard to diagnose, and who need special testing even to be able to make the diagnosis, right? So how can we identify each and all OT patients faster and easier? So we decided that, we needed to enhance our ability to assess the patients and identify the patients first, to give tools to all healthcare providers that can help increase the chance of getting the patients diagnosed first. So we started on that path and created a number of tools and studied a number of options. Included, that first study using a smartphone app to provide a simple, accurate bedside screening tool for orthostatic tremor. And the importance of this study that we published a while ago is that it allows for a fast and accurate diagnosis without the need for expensive tests or advanced expertise. And it's very simple. We attach the mobile to the leg and have the patient standing, and then we do the assessment for about 30 to 60 seconds, and it measures the tremor and it produces peaks. And in this particular case, you can see how the peak is around 17 hertz, which is characteristic of orthostatic tremor. In this other app, you could see how it measured different peaks, and the main peak was around 15.5 hertz. So we proved that by using apps, we could actually diagnose the patients, screen for them quicker and easier. We also, in one of our visits with the patients, one of the meetings in Omaha, the patients started talking about, the thing that when they're standing, they tend to curl their toes. They say that it feels like they are grabbing the floor sometimes. And we decided to call that the plantar grasp sign. And we studied the possibility of using it as a screening tool. And due to the high sensitivity and specificity, we said that it could be considered to screen patients with possible OT. So, we have many more things that we have completed in regards to diagnosis and to identifying the patients, including the orthostatic tremor screening questionnaire and video magnification study and the plantar grasp sign and the OT app and others. Recently, this paper was published, which I found absolutely fascinating. It's not that humans are like dogs, for sure, but this particular study was evaluating the possibility, the presence of orthostatic tremor, both primary OT and OT plus in dogs, and they were reviewing 60 cases with it. And to me, I mean, this came mostly from Europe, from the United Kingdom and other countries. But I was just fascinated by this. How can how could they tell that dogs had it if this is a disease that is one of mostly the patients telling you about their feelings and the suffering, and the feeling of imbalance. But yet they studied it, and it was really fascinating, and they were able to divide these between primary OT and OT plus, and they said that some of the dogs had generalized OT, all 4 limbs plus head and trunk, but other dogs had mostly pelvic limb OT. So this has opened up another avenue for us to think about the disease and try and help our patients. And they published some treatments that they use for primary orthostatic tremor. And as you can see, some of the dogs had complete resolution of their symptoms by using gabapentin, valproic acid, clonazepam, and complex B vitamins. And then the majority of dogs, however, who tried the multiple medications, the majority of them, continued to have some symptoms. So it's something that, we're going to continue to think about. But in terms of our ongoing projects, I have listed here the ones that we're working on right now. The ones that we're interested on publishing in the next couple of years. And we are really not stopping until we are able to answer the many questions we have. And this is what we're working on right now. And then the future projects are, this humongous long list of options. And believe me when I say that we would love to go faster, but research is slow, and you need resources, and you need people, and you need scientists, and you need money to be able to do all of the things that we need to do. So we'll continue to work hard on on trying to find all of the answers for our patients. And with that, I would like to thank all of the patients who have participated on the studies and all of the research participants. To remind everybody that September is the Orthostatic Tremor Awareness Month. Actually, the idea came from a patient from Australia. So, I am very, very glad and very thankful that I was able to be with all of you today, and that you invited me to speak. And I look forward to the opportunity to meet all of you in the future. The OT family is a small family. I hope that at some point we will be able to shake hands and share thoughts and ideas on how to improve everybody who is dealing with this condition. Thank you so much for your attention, and I wish you a wonderful meeting in Melbourne, Australia. Thanks.